Orthokeratology, from vision correction to myopia control. Good afternoon. My name is Gulnara Adrienko. I represent a Russian National Myopia Institute based in Moscow. I am an ophthalmologist and a research officer of the Orthokeratology and Myopia Control Department and educator at the Russian Academy of Medical Optics and Optometry, where I teach a course in orthokeratology. In addition, I work as a professional consultant to OK Vision Lab based in Moscow. Let's talk about orthokeratology. Orthokeratology is a method aimed at correcting refraction errors such as myopia, hyperopia, and astigmatism. It employs the use of reverse geometry, rigid gas permeable contact lenses to achieve adjustable and reversible reshaping of the anterior corneal surface. Orthokeratology has become a convenient alternative to soft contact lenses, spectacles, and refractive surgery. Over the past decades, orthokeratology has accumulated a strong evidence base and become widely used in clinical practice as an effective intervention to slow myopia in children and adolescents. Both adults and children love orthokeratology lenses for high-quality vision and complete freedom from glasses and contact lenses during the day. We recommend it for adult patients if they feel tired of using glasses and contact lenses or are not very happy with the results they provide. For the patients who are, in addition, do not choose refractive surgery because of personal preference or contraindications. Orthokeratology is especially recommended if sports activities are an essential part of the patient's life, if their job requires excellent vision, but for some reason is incompatible with spectacles and contact lenses, if the patient has been using contact lenses for many years, but recently started experiencing discomfort and dryness. We feel that orthokeratology is a modality that can be extremely successful in such cases. Orthokeratology is popular with children and adolescents as well. Children and adolescents are especially active, and wearing spectacles or contact lenses during the day can be restrictive. At the same time, refractive surgery is irreversible and therefore cannot be applied. Reversibility of the changes in the corneal shape is an important advantage of orthokeratology compared to refractive surgery, especially in children. In line with orthodontics, orthokeratology solves not only a cosmetic problem, but also helps prevent a deterioration in the quality of life in the future. By slowing myopia progression in childhood, we can reduce the likelihood of possible complications of myopia in the adult years. If a child or adolescent refuses to wear glasses or they restrict sports activities, if it's important for the parents that the child applies and removes lenses and takes care of them under their supervision, if the parents are tired of changing their child's spectacles because myopia is rapidly progressing, then perhaps it's time for them to seek an advice of an ortho-K specialist. Since the introduction of rigid contact lenses, corneal reshaping occurring due to wearing lenses has always been considered an undesirable side effect. However, the American optometrist George Jasson discovered that in patients with myopia, a lens with a flatter radius of curvature resulted in a temporarily improved visual acuity after its removal. This is how, in the early 60s of the last century, the idea of deliberately changing corneal shape using rigid contact lenses arose for the first time. Jasson continued to observe the results of fitting flatter lenses made of PMMA for myopic patients, and later patented the orthofocus fitting technique. This method attracted the attention of ophthalmologists and optometrists. However, over the next 2 decades, orthokeratology failed to gain widespread application in clinical practice and the recognition of the scientific community. Practitioners faced issues of decentration and induced astigmatism, and the overall refractive effect was insufficient and unstable. Researchers were concerned about the consequences of changes in the central cornea. In addition, the specialists lacked tools for assessing the effectiveness and safety. They were only able to rely on keratometry and biomicroscopy. It took several decades for orthokeratology to be adopted by both researchers and practitioners. This was facilitated by several milestones. A new reverse geometry lens design was developed, and digitally controlled lathes appeared on the market. And, in addition, highly oxygen-permeable lens materials were developed. Also, finally, corneal topography became widely available, which made possible objective criteria for assessing corneal shape before and after wearing Ortho-K lenses. In 1994, the US FDA approved the first orthokeratology daytime wear lens, the Contax OK lens. Year 2002 was a decisive year for orthokeratology, when the Paragon Company first received FDA approval for corneal refractive therapy, CRT, overnight orthokeratology, as an effective and safe method of vision correction for patients from 6 years old. Within a few years, the first study results were published, indicating that orthokeratology was able to slow axial elongation in children with myopia. Earl Smith's publications regarding the effect of relative peripheral defocus also appeared. Thus, the era of optical strategy for myopia control was opened. In the middle of the last decade, Ed D. Cho, a Canadian optometrist and lens design software developer, shared his experience of modifying the optical zone of the lens. This is how specialty Ortho-K lenses for children and myopia control appeared. On the 12th of May 2021, Johnson & Johnson Company issued a press release informing the professional community that the FDA has approved ability overnight orthokeratology lenses for slowing progressive myopia in children and adolescents. This is the first FDA approval in the history of orthokeratology related to myopia control. The press release cites clinical trial data that support the approval. The lens is expected to hit the US market in late 2021. On the 25th of May 2021, the Dream Light orthokeratology lens by CooperVision received the European Certificate of Conformity and was approved for slowing progressive myopia based on results of a 2-year randomized clinical trial. Let's take a look at how the orthokeratology lens works. It consists of several zones combined into a single unique design. As we can see on the figure 1, each zone has its own surface curvature and functional purpose. The term reverse geometry is based on the relationship between the curvature of the lens in the central optical and return zones. The curvature of any daytime wear contact lens gradually flattens from the center to the periphery, mimicking the shape of the cornea. An orthokeratology lens is designed in a different manner. The curvature of the lens in the center zone is flatter than the cornea, while the subsequent return zone has a steeper curvature. The steeper radius of curvature of the return zone allows the lens to return to the surface of the cornea. The next zone of the lens, the alignment zone, must fully align with the surface of the cornea at the periphery to ensure a proper effect in the center. For each zone, the required lacrimal gap, or the so-called clearance, is determined. It must be noted that in the center zone, it is minimal, but should amount to at least 5 to 10 microns. Preservation of the tear layer is necessary for a neat and safe effect on the corneal epithelium. The middle periphery is responsible for the uniform support of the lens on the surface of the cornea. This zone is called the alignment zone, which allows the lens to be centered. By modifying the parameters of each zone, Ortho-K specialists are able to control the change in the tear clearance with a precision accurate to a micron. When staining with fluorescein, in those zones where the lacrimal gap between the lens and the cornea is greater than 15-20 microns, it becomes visible and we can evaluate it. This helps understand what changes should be made in each particular zone. In order to improve the optical effect, we modify the center zone. To adjust the fit of the lens and its centration, we modify the alignment zone. Due to the uneven lacrimal layer under the lens, the thickness of the epithelial layer of the cornea changes. It is the lacrimal layer that plays a major role in achieving the required refractive effect. Changes in the anterior layers of the stroma are minimal and practically do not affect vision. In contrast to refractive surgery, the effect of orthokeratology is due to not only a decrease in the thickness of the epithelium in the center, but also to an increase in its thickness in the paracentral or middle zone. The cumulative effect of these minimal changes in the corneal shape result in a significant changes in the optical power of the cornea. The correction of the refractive error and the stabilization of the obtained results occur gradually. Depending on the severity and type of metropia, the process may take from 1 to 4 weeks. At the same time, the refractive effect and changes in the thickness of the epithelium are temporary and completely reversible. In clinical practice, we use corneal topography to assess the surface of the cornea and changes in its shape. In some cases, optical coherence tomography can also be of help. We can estimate how much the thickness of the cornea and, in particular, the epithelium has changed. Normally, this change does not exceed 20 microns. Therefore, they are not so easy to see on the OCT image. They are almost invisible in cases of correction of mild myopia. It is placido-disc-based corneal topography that provides the most precise information about the surface of the cornea. Orthokeratology specialists need to carefully assess the shape and features of the cornea prior to fitting in order to choose the correct lens design and appropriate parameters. After lens use, the topography provides information regarding where the lens was during sleep and what refractive changes it achieved. Axial maps show refractive changes in the cornea. The area of flattening in the center, its shape, size, centration, and regularity. Tangential maps show the changes in the shape of the cornea, how the curvature of the cornea changes, how the defocus ring is formed, its size, uniformity, its centration relative to the pupil and the optical axis. Corneal toricity on the periphery affects the result. Therefore, even before fitting the lenses, we need to estimate the peripheral toricity in the 8 mm chord. The difference between the flat and steep meridians greater than 30 microns is considered critical. Companies that produce corneal topographers have added an option of measuring corneal toricity in the 8 mm chord to make it easier to choose the appropriate lens design, either with spherical or toric alignment zones. We wanted to know how often the need for a toric lens design occurs, which is why we analyzed topography images of nearly 600 patients. We found out that almost half of the patients, 44% of them, according to the corneal topography data, have a peripheral toricity of 30 microns or more. This means that almost half of our patients need a toric alignment zone design. This is crucially important as some lens inventory sets are still only equipped with spherical lenses, while toric lenses are suggested to be ordered in case of necessity. Currently, we understand that almost every second patient requires toric lenses. Underestimation of toricity and inappropriate design of the alignment zone are the most common causes of lens decentration and induced irregular astigmatism. We pay great attention to the precise estimation and adjustment of the alignment zone parameters and toricity for the maximum possible centering of the effect. Therefore, in cooperation with the OK Vision Laboratory, we have created diagnostic lens kits that include both spherical and toric lenses of different diameters. Fitting orthokeratology lenses involves choosing the best possible lens for each patient. Therefore, depending on the situation, we can use several levels of design complexity. Standard design. The use of standard designs involves fitting ready-made lenses from the manufacturer's inventory kit. Working with lenses of standard design is quick, convenient, and justified if the refraction and the shape of the patient's cornea are within the range of parameters of such lenses. Optimized design is recommended in cases when, after fitting a lens from the inventory set, practitioner sees that minor changes to the original lens parameters are required for a better result, And finally, a customized design may be required when we deal with very specific parameters of the patient's cornea and need to correct a relatively high refractive error or to slow myopia progression. When designing custom lenses, we can manipulate the shape of its central part, which allows us to significantly expand the possibilities of orthokeratology for patients with hyperopia, astigmatism, including simple myopic or complex hyperopic, and even mixed astigmatism. Now, let me demonstrate this with a few examples. This is a view of a fully toric RGP lens designed for correction of simple myopic astigmatism, in which the tear profile is designed for flat and steep meridians differently. Biomicroscopy lets us see that in the flat meridian, the lens is almost parallel to the cornea throughout its entire length, which means that its effect is absent. At the same time, in the steep meridian, the lens profile is intended for correction of myopia. 3D topography map clearly shows the different refractive effects in each meridian. And this is how a lens for hyperopia correction looks like. In this lens, an extra zone with an increased clearance is added in the center, which results in an increase in curvature and therefore correction of hyperopia. This is a case of correcting a complex hyperopic astigmatism. As we can see, the width of the optical zone is different in the flat and steep meridians. This is perhaps the most interesting case, a lens for the correction of mixed astigmatism, in which each meridian is designed separately for correction of myopia and hyperopia. Let's see what changes occurred after wearing this lens. In the optical zone, there was a decrease in astigmatism and change in the optical power, an increase in the flat meridian and a decrease in the steep one. Isn't that spectacular? In most cases, orthokeratology lenses are used for myopia correction. Recently, children have become the main users due to the myopia control effect that can be achieved with orthokeratology lenses. Myopia onsets early, progresses rapidly, and refractive error becomes high quickly. As a result, the risk of complications associated with myopia is significantly increased. The International Myopia Institute, IMI, proposes to consider myopia as a chronic progressive disease caused by an excessive increase in axial length, associated with the risk of complications leading to decreased vision, accompanied by refractive disorders. What concerns the doctors? Over the past 20 years, the prevalence of myopia has almost doubled in both Eastern and Western countries. More than 80% of young people in the Asian region and 50% in some European countries today are diagnosed with myopia. Early onset of myopia, rapid progression, and, as a consequence, a higher degree of myopia eventually inevitably lead to an increase in the number of complications in adulthood. An increase in myopia by 1 diopter increases the risk of myopic maculopathy by 67%, so it becomes difficult to talk about a safe level of progressive myopia. Although initially orthokeratology was a method for correcting refractive disorders, it found wide clinical application in slowing myopia progression. In 2005, Dr. Cho and colleagues published the results of a study that revealed the effectiveness of Ortho-K lenses in slowing the progression of myopia compared with a control group of children wearing single-vision spectacles. Following the publication of the encouraging LORIC study data, other studies followed to evaluate the effectiveness of myopia management with orthokeratology lenses in children. Currently, the effectiveness of myopia control with orthokeratology in children and adolescents has been confirmed by a number of randomized clinical trials. Depending on the study design and duration of the studies, the effect of slowing axial elongation ranged from 32% to 63%. It is assumed that the major mechanism of the inhibition of myopia in orthokeratology is retinal peripheral defocus. According to this hypothesis, Due to the change in the shape of the cornea associated with wearing ortho-K lenses, a relative peripheral myopic defocus is formed on the retina. Researchers consider that peripheral myopic defocus plays the major role in the regulation of eye growth. This has spurred research into the effects of peripheral defocus and the development of new products able to control myopia progression, such as defocus-inducing soft contact lenses and spectacle lenses. Another theory explaining the inhibitory effect of myopia progression with orthokeratology is associated with the assumption of the influence of positive spherical aberrations on the accommodation and changes in the choroidal thickness. We have yet to master and explore these techniques, but one thing is certain. A potentially greater effect of myopia inhibition may be achieved if treatment is started at an early age, before 9 years old. Observation of ocular component growth curves among 4 refractive error groups in children, persistent hyperopia, emmetropizing hyperopia, emmetropia, and myopia, helped us better understand the possibilities and prospects for prescribing and evaluating the efficacy of orthokeratology. The growth curve in myopes differs significantly from the other 3 groups. The study of growth curves in these groups of children helped us understand that the best possible result is to approach the growth curve of emmetropic children, which means that the inhibition of myopia is limited. What do we expect from orthokeratology today? I would like to recommend that you go through Clear International Orthokeratology Review, which states that new lens designs allowing for adjustment of the treatment area or other parameters can improve lens fit and the efficacy of myopia control. In a joint report by the European Society of Ophthalmology and the International Myopia Institute, it's recommended to consider another method of myopia control for patients with myopia lower than 2 diopters and pupil width smaller than 4.5 millimeters, if customized orthokeratology lenses are not available. Why? Orthokeratology results in changes in peripheral refraction, which is the case for all degrees of myopia. However, defocus changes are in relative correlation with the baseline myopia. This means that in case of mild myopia, the degree of peripheral defocus will be much smaller. Research papers confirm that the pupil width affects the area of peripheral defocus. Therefore, it becomes clear that it is not advisable to use standard design lenses for myopia control in children with mild myopia, lower than 2 diopters, because the peripheral myopic defocus will be insufficient. Adi Cho also confirmed smaller efficacy of myopia control in children with myopia up to 4 diopters when using orthokeratology lenses with a conventional optical zone. In 2016, he published another study. To enhance the effect of myopia control, he proposed increasing the compression factor, adding asphericity while reducing the diameter of the optical zone. Currently, the research aimed at studying how changes in the optic zone diameter and lens design can enhance anti-myopic effect continues. However, the efficacy of customized orthokeratology lens designs is to be further investigated and evaluated in prospective randomized controlled trials. I would like to tell you that for several years now, we have been fitting specifically designed lenses for correction of myopia and myopia control in children. We carried out a retrospective analysis of records of 90 patients aged between 6 and 12 years, with myopia ranging from 0.5 to 4 diopters and astigmatism up to 3 diopters. Data analysis included an assessment of axial length changes every 3 months over a 24-month period of wearing customized orthokeratology lenses. This slide shows corneal topography images of an adult patient's eye after wearing ortho-K lenses for myopia correction, and topography images of a child's eye after wearing ortho-K lenses for myopia control. You can see the difference in the optic zone diameter. At the same time, optic zone in an ortho-K lens for myopia control exhibits a greater variation in refraction. In total, medical records of 42 children aged between 6 and 9 years, Group 1, and 48 records of children aged between 10 and 12 years, Group 2, were analyzed. All patients had baseline myopia lower than 4 diopters and have been wearing customized Ortho-K lenses for 2 years. These lenses had an aspheric design of the back optic zone and a reduced back optic zone diameter, resulting in a return zone depth not less than 60 nanometers. On this slide, we can see biomicroscopy view of the lens fit, axial and tangential maps, as well as axial length measurements, which helped plot a chart comparing rate of axial elongation with age-appropriate normal axial elongation rate in emmetropes.
С помощью этих данных выстраивался график, и график роста аксиальной длины сравнивался с данными естественного роста глаза в норме у эмметропов по исследованию Карла Задника.
In both groups, we compared the mean axial elongation with the ocular component growth curves typical for emmetropia and myopia, according to methodology by K. Zadnik and colleagues. We discovered that the mean annual axial elongation by the end of the study amounted to 0.18 millimeters in the group of children aged between 6 and 9 years old, which was very close to the values typical for emmetropes. It is marked with a blue line. Axial elongation correlated with the age at start of lens wear, but not with gender and baseline refraction. The mean annual axial elongation at the end of the study in the group of children of 10 to 12 years old amounted to 0.06 millimeters. During 24 months of follow-up, axial elongation in patients with customized Ortho-K lenses for myopia control was significantly smaller than in previously published studies related to Ortho-K lenses of standard designs. To sum up, the mean axial elongation per year in the group of children of 6 to 9 years old was close to the values typical for emmetropia. In the group of children of 10 to 12 years old, it was smaller than the value typical for emmetropia. Thanks to optical biometry and the comparison of the obtained data with the age-appropriate normal values of axial elongation, we discovered that we are indeed able to successfully approach the natural rate of axial elongation in 70% of children fitted with specialty Ortho-K lenses for myopia control. This result confirms that orthokeratology remains an effective method for myopia management. Modifying the optic zone of orthokeratology lens, adjusting the diameter, and introducing asphericity allows for manipulation of peripheral defocus and induced spherical aberrations values, which can be used to increase myopia control efficacy. Like other interventions for myopia control, orthokeratology provides the greatest benefit in case of early acquired and rapidly progressive myopia. It is necessary to early detect the risks of myopia by measuring the axial length and comparing the elongation rate with the age-appropriate normal values. It is necessary to inform parents about all currently available methods of myopia management, including optical correction, specialty multi-segment spectacle lenses, defocus-inducing soft contact lenses, and customized Ortho-K lenses. Thank you very much for your attention. I would like to invite you to visit the website of the Russian National Myopia Institute and the Russian Academy of Medical Optics and Optometry. We are sure that you will find a lot of interesting information. Thank you.